Hello, everybody. My name is Natalie Hayden. I'm so excited to be here with you today. We are going to be talking about family planning and pregnancy as it relates to autoimmune conditions. First of all, I just want to introduce who is going to be speaking on the panel beside me today. First of all, it's Dr. Marla Dubinsky. She runs the IBD Center out of Mount Sinai in New York. She also is the Director of Preconception and Pregnancy Planning at the clinic in New York. So thank you so much for being here, Dr. Dubinsky.
Thank you so much, Natalie.
And we also have Mariah Leach. She leads Mamas Facing Forward, which is an awesome organization that we'll be talking about shortly. But she also was diagnosed with rheumatoid arthritis at age 25, and she's had 3 kids since. Thanks so much for being here, Mariah.
I'm happy to be here.
We're happy to have you. And I'm also a mother of 3. I have Crohn's disease. I was diagnosed in 2005, and I am the founder of Lights Camera Crohn's, the blog, and I talk a lot about pregnancy, family planning. My youngest is 3 months old. So let's kick it off and first of all, talk about medication when it comes to family planning. This is a topic so many women wonder about. We get so many questions in the patient advocacy community. Dr. Dubinsky, can you talk about the safety and efficacy of biologics in pregnancy?
Sure. So there's a couple of things to note is that there's biologics, but there's also some newer therapies that I'll talk about in a moment, which are called small molecules, which are pills. So they're a little bit different. And it's an important distinction I'm going to make because the timing of exposure to the baby while it's growing and as a fetus doesn't get exposed to any biologics. Not one biologic that a woman takes during pregnancy is the baby exposed to until you start getting into the late 2nd, early 3rd trimester. And the reason why that is so relevant is because the time when these medicines need to be taken is when you're trying to get pregnant or just newly pregnant. And the fact that they don't even affect the baby's development means there's absolutely zero need to stop any biologic therapy. And it is probably the biggest gift that you can give your child and yourself is for you to stay on your meds, because the biggest risk for the baby is growing and developing in an inflamed environment. And that is what we know is that when you're inflamed, when you get pregnant or during the 1st trimester, there's a 4 times increased risk of miscarriage by being inflamed. So the fact that the meds that you're on don't even communicate with the placenta or communicate with the growing fetus, it gives us this really great opportunity to keep ourselves well under control. I just wanted to mention that small molecules, which are pills, do cross the placenta. So it is important to know what kind of drug you are on. Any of the drugs we give through IV or self-injection, which are typically the biologics, do not cross the placenta. Pills such as our newer pills like tofacitinib, which is approved for both rheumatology as well as ulcerative colitis, does cross the placenta. And currently we are not recommending women get pregnant on them and needing to stop. And there's a new ulcerative colitis therapy that was approved a couple months ago called ozanimod for UC again, and that needs to be stopped 3 months before conception. So there is important information that you need to know what med you're on, what type of med, and when or not you need to stop it.
That's such a beneficial and important message because I know, Mariah, you can probably relate to this as a chronic illness mother. So many of us deal with mom guilt, having to stay on our medication in order to keep our disease at bay, to bring a healthy baby into this world. And I stayed on my biologic through all 3 of my pregnancies. Mariah, can you talk about how you navigated your medication through each process and pregnancy?
Sure. Like Dr. Dubinsky said, there are some medications that are not recommended. In rheumatology, the big one is methotrexate. Generally, you need to get off of that before you conceive. But I think it's so important to weigh the risk of being off your medication. I think a lot of times when we talk about being on medication, you think of the risk of taking the medication and will it affect your baby, and it's scary, and I can certainly attest to that, having had to make these decisions myself. But I think you're not comparing that to being off the medication. It's not, you compare it to being what happens to your body when you're off the medication, and there's definitely downsides to not being on them. And so I was unable to be on biologics for most of my first 2 pregnancies because there wasn't as much data available at the time, and back then they weren't advising you to be on it unless there was a really severe reason to, like a very big flare. And I can tell you that I did a lot worse during those pregnancies. Those pregnancies were more difficult, and the postpartum period was more difficult. I had very bad postpartum flares with both my first and second baby, even though I restarted a biologic in the middle of my second pregnancy. But with my third baby, I stayed on a biologic the whole way through, and I had a much easier pregnancy, and I had no postpartum flare. And so I think it was safer and healthier for me to keep my disease under control, and that's safer and healthier for baby too.
It sure is. And when you're making these key decisions, when you're trying to think about conception and family planning and pregnancy, it is imperative you have a care team of support around you. So we're going to touch on maternal fetal medicine specialist. Dr. Dubinsky, can you speak to what's the difference between an OB-GYN and an internal or a maternal fetal medicine doctor?
Sure. So a maternal fetal medicine doctor, there's other terms that people use, which sound scary, such as high risk OB. And it infers that I'm a high risk pregnancy. Not really. It just infers to me just very better, tighter care. I try and explain that it just means you'll be watched closely by a team that is focused on maternal outcomes. Most general, OBs that deliver you or OB and your gynecology, they're more generalists, shall I say, and their focus is often the baby and often don't have as much experience counseling around the safety of the medications, because I can't tell you how many patients have come to me flaring in the first or early second and told me that they're pregnant, but they were told by their OB to come off their medication. They never saw someone to talk about the safety of their medications exactly like we just did. The other term people use is perinatologist. So there's sort of terms that are used for these MFMs, or maternal fetal medicine specialists. They're the ones that are scanning your baby. They're the ones that are constantly having the ultrasound machine on your belly during pregnancy, but they may not be talking to you specifically about the questions that you most want to know. So what I tell my patients is that you should be seen at least once and have a consultation, true, not just scanning your belly to look at your baby's growth, but actually have a consultation to talk about your meds and prepare for mode of delivery that we'll get into, because there are some considerations in both room and IBD space that need to be taken into account. But I think it's important for everyone to be on the same page. And this is what leads to confusion, chaos, myths, voluntary childlessness, even the idea that maybe my OB told me I can't get pregnant on this medicine. And I'm so afraid. I had a perianal abscess, I've had a stoma. There's so many stories that come into it. And the fact that it's completely, there's non-entity, you could absolutely get pregnant on that medication, always elicits something very emotional in me and my patient, because they've been told something very different and not correct. So anybody who hears from an OB that they need to stop their meds, at least in IBD, you need to pick up the phone, you need to call your gastroenterologist before you do anything. That's a very important message. And I don't know, Mariah, if you had the luxury of having a consultation or being followed closely with an MFN during any of your 3 pregnancies.
Did actually, and I actually consulted with an MFM prior to my 3rd pregnancy, because I knew that the data had changed somewhat since my first 2 pregnancies. And at the time, I was on a biologic that was not particularly advised for pregnancy. And so I went and saw an MFM, and we came up with a new treatment plan that would work for my RA and be safer for the baby. And, even if the MFM isn't, they're not a rheumatologist, right? So they don't know all the rheumatology drugs necessarily. The one that I was considering switching to, she had not heard of, but she did the research and she figured it out. And we looked at the data together, and she was qualified to make those decisions. And I will say that one of the things that comes up in my group, the support group that I run for moms with chronic illness, whether it's IBD or RA or some other chronic illness, is getting mixed messages from their doctors. The OB says one thing, the rheumatologist says another thing, and patients don't know what to do. And a maternal fetal medicine specialist can be a really good third party to help you kind of work out what the right decision is there.
There's so much gray area, which is making it so hard on so many women, because they get one direction from one physician and then their other doctor may say something else. But through all my experiences, I found an education ahead of time and just empowering myself with knowledge and going into my OB and talking with her about what my GI said and what my MFM said, and made me feel stronger and more in control of my pregnancy. And I was amazed at just how my OB would listen to what I had learned along the way. And she would often ask me questions. So it's truly a team collaborative effort. It's not just your doctor speaking to you as a patient, it's also you articulating your concerns, your fears. How am I going to navigate a flare if it happens? Kind of being proactive in your approach so that you feel like you are in control when so much seems like it's going haywire, or maybe you're just worried about the possibility of a flare.
Yeah, it's one of the most emotional gifts a woman, at a time or transition in their lives. And I think guilt does come into play a lot about even passing down the disease. I'll sort of give you where I start with the messaging a little bit, is I know that women are coming in holding their breath, waiting for me to either give them permission to just go and get pregnant. Like they said, don't do anything until you talk to Marla, whoever gave them that advice. So they're like, didn't do anything until they talked to me. But the fact, when I say, and the risk of passing on these diseases is extremely low. So they're shocked at that. They thought that their baby is for sure going to be, at risk. So that's one important conversation I have. And then, of course, the myth around the medications, which we already addressed, or the misunderstanding that my disease will flare during pregnancy. There's a lot of that. Like, I'm finally, as I noted before, in a good place, and I'm worried that something's going to trigger and it's not going to go well. I'm going to harm my baby. So all of that, I know what the elephant in the room is when I walk in, and sort of go after it right off the bat and say, before we start getting into the nitty gritty of what med and how long we continue it and when is your last dose and all the inertia around that, you need to just be, very clear up front that you are going to get pregnant. We will get you pregnant. If it's not naturally, we'll figure out a way how to get you pregnant. I'm not intimately involved in every step, but I will find out exactly how I can get you there. And demystify, probably in the IBD space, which Mariah is a little bit unique to your scenario, is we have the added confusion about our colorectal surgeons and patients who've had surgery, for example. One of my happiest days are when I take a patient who's had their colon removed. And if you look all over the internet, it basically says you can't get pregnant if you've had a colectomy and if you had a J pouch surgery, which is the creation of, continent, sort of a new rectum made out of your small intestine. And there's all kinds of misinformation about that. And being able to tell a woman that, oh, you can get pregnant. It's not that your uterus can't carry a baby. It's just that there may be some scar tissue. And we just have to go in, figure out, do a scan. And if you do have scar tissue, we set you up with our fertility specialist and we figure out another way, whether it's assisted reproductive technology, which we've done a lot and published a lot on its effectiveness. But I think the joy of me demystifying what happens when they sit in front of me is like my best day ever, which is Wednesdays. If anyone wants to know what day of the week is my happy day, it's Wednesdays. But the ability to really demystify and give people empowered information so that they feel relief and no guilt, or as little guilt as possible, I think is really what your groups, both of you, are focused on. And also those of us who are interested in the space, we just want to be a resource of truth is really what we need to be. And you need to find that resource of truth.
And my big question I often get from many women in the IBD community who are flaring and really desperately wanting to get pregnant is just the battle of being patient, knowing when to pull the trigger, when to start trying for a family. I personally was very blessed. I was in remission from surgical remission from bowel resection surgery right before I got married, and I got pregnant 1 month after I got married and had 3 subsequent pregnancies after. So I can't personally speak to that struggle of desperately wanting to be pregnant. You see your biological clock ticking, your disease is flaring. What is your advice for women out there who want to get pregnant but are scared because they can't get their disease under control?
100%. I mean, I want to also emphasize that the biggest risk to fertility is age, ladies. So we have to be honest about the fact that age is a much bigger factor than any disease or any medication. And that I like to actually set up front, because we're all, our biological clocks don't necessarily advance or slow down because of one disease or another. So I did want to put that out there, but that does take into account, Natalie, how aggressively I counsel is if you're older and we're not getting your disease under control, I'm even more assertive and aggressive with getting your disease under disease control, because I am limited somewhat by time. I do have time. I'm on a clock a little bit in my work to get you pregnant. But I think the biggest gift again goes back to if you conceive in a disease remission state, like Mariah was clearly telling you the same thing, the importance of going into conception on medications in remission will totally change your journey throughout gestation and postpartum. I mean, Mariah, you laid it out like so fabulously for me in terms of like every step is tied to inflammatory control. So Natalie, there has been times where literally they came to me and the next day they were going to do even embryo transfer. And I'm like, you are not doing embryo transfer tomorrow. Like I was their last stop on the embryo transfer train. And I was like, this is not the time. Implantation will be affected, miscarriage rates. I need to get your disease under control. And I'll tell you, Natalie, doing surgery has been the way to get some women under control because they've been through multiple medications and no one is because they were all afraid of pregnancy and surgery. I'm like, look, if we get the disease out, we're starting from scratch. So it is worth delaying things by, even if it's 4 or 6 months. At the end of the day, the most important thing is that you have a successful conception, a successful, development of the fetus in gestation, and you can breastfeed healthily, and you can have be an amazing mom once the baby's born, because that's another level of stress and transition. So my answer to you is everything possible on the table, quickly get you into remission, and I will get you pregnant, right? That's the messaging. I've walked out of the endoscopy suite and people are a little groggy from propofol, and I'm like, when are you ovulating? They're like, why? Tomorrow. I'm like, go for it. You're ready to go. Giving the pat, and the husbands are a little freaked out, that I'm like telling them right now to go and try to conceive. But I think it's important to understand that emotional connection to being in a good, healthy state, that you can really feel happy and excited about getting pregnant.
I love that you say that, because prior to all 3 of my pregnancies, I did a colonoscopy to get the green light from my GI, and she would walk in just like that and give us the thumbs up. And we were so excited each time to have that. I'm actually having a colonoscopy next month. It'll be my first time not trying for a baby after.
You're going to have a baby. Okay.
Now, Mariah, when we talk about modes of delivery and mamas facing forward, what type of questions or comments do you see come up quite often?
Well, I mean, I think a lot of the people in Mamas Facing Forward are living with some form of arthritis, because that's what I live with and that's how it is spread. And I think there's often concern about how your joints will do during a delivery and what that will be like. And I have to say, delivery is still a mystery to me. I have 3 babies, but all 3 of mine were C-sections. And I was never even in labor. So it's funny how there's still parts of this that are a mystery to me, but not related to my RA. That happened because of other reasons. And so I think in most cases, what I have learned is that either mode of delivery is possible and appropriate depending on your situation.
Okay. Yeah, and I'm the same way. I actually had 3 scheduled C-sections, never dilated or anything. We're on the same boat there. With Crohn's and ulcerative colitis, it's a bit more complicated with delivery when it comes to perianal disease and things like that. I know my MFM gave me the choice. They said, what do you feel most comfortable with? Even though you don't have perianal disease, Natalie, would you feel more comfortable? You never know if a fistula could develop or healing down there. So I said, I want to go with a scheduled C-section, and my care team all around was supportive of that. What do you talk about with patients, Dr. Dubinsky, if they come to you and they're concerned?
Yeah, so I think mode of delivery is one of, actually, just like Mariah said, it's one of the mysteries about sort of like, do we get it right? Are we right? If you start off agnostic to disease, even MFMs as well as OBs will tell you that the safest mode of delivery is vaginal delivery. Your recovery is faster. It's not abdominal surgery. I'm doing it at a high level before I get into the details of it. So that's how they're going to approach it typically, unless, from disease agnostic. Secondly, they're going to say, however, during pregnancy, there may be things, and maybe both of you ladies experience, but preeclampsia, which is high blood pressure, baby is breech, you have liver disease of pregnancy, whatever. There's a laundry list of obstetrical reasons. Baby isn't progressing properly, or baby's too small, whatever. Amniotic fluid stuff, we need to hurry up and get the baby out and not have you induced in labor. There's a lot of reasons why OBs, MFMs, and routine general OB will tell you why you need a C-section. That's separate. then let's dig deep into the disease characteristics that are black, gray, and white criteria. So I'll speak. You mentioned, Natalie, appropriately, that active perianal fistulizing Crohn's disease, which for those of you who don't have Crohn's or don't know what I'm even talking about, is there is a segment of Crohn's patients who develop tunnels from their sort of anal canal or rectum out to the skin and develop infections and these tunneling out to the surface of the skin, which can be create damage to the anal sphincter, or the sphincter, which contains continence. Okay, this is how we are all continent, is our rectal and anal sphincter must work. Now, when you are pregnant and have a huge pressure in the abdomen, regardless of IBD or not, you have pelvic pressure, you are going to have a weaker pelvic floor. The more vaginal deliveries you have, the more pregnancies you have, you're going to have more possibly peeing when you cough, doing jumping jacks, whatever it ends up, but pelvic floor becomes weak. You guys could tell me if I'm off on what I'm saying. And that's, again, regardless of mode of delivery, regardless of underlying disease. So if you have something that is already compromising your sphincter, your pelvic floor, your sling that keeps you continent, and you have a tear of grade 3 or 4 through a vaginal delivery, that means it sort of goes backwards and could harm the sphincter that keeps you continent. Okay, so from a perianal perspective, that wouldn't be great. Tissue healing would be very difficult, and you may have incontinence on a routine basis. So that's why we say active perianal, that's the only absolute contraindication for vaginal. However, what about relative? Like you didn't have it, but the MFM may offer it because you have a disease whereby continence is important. Any GI disease, and someone with really bad ulcerative colitis who's like a day away from a colectomy, but I've had to fight hard to get their disease under control with multiple medication, and they may need a J-pouch surgery, the surgery I referred to before. I need them to be as continent as possible. And so I have a very strong bias, and that's my experience. Not everybody will agree per se. Women who've undergone a J-pouch, I need you to be continent because you all have a lot more bowel movements than someone without a J-pouch. I would like you to have a C-section unless for some reason you cannot. So that's, for me, my gray black area, where I've made it more absolute. In terms of patients who've had small bowel surgery like yourself, historically, if you've only had small bowel disease, no perianal, your colon's been great, then there's really no reason for you, in theory, from a disease perspective, why you can't have a vaginal delivery. So it's really sort of very specific to who's advising you, your disease history. Do you have pelvic floor dysfunction, vaginismus? Most GI doctors don't even talk about sexual health and don't even take that into account, and the impact of having pelvic floor dysfunction on vaginal delivery. It's so complex that it really takes a specialist, and that's why you need the team, the village, who understands all of this. And then in Mariah's camp, people who've had hip issues from steroid use, people who've had sacroiliitis, which is inflammation in your sort of hip, the back of the back, lower back joint, and you're going to be pushing for hours. Is that really the best way on your joints, right? So that was sort of in functional or the way you, if you're laboring for a long time, that may impact whether you should get a C-section or a vaginal. So you need an expert. You don't take it from one person. You ask the village, and you make sure you are getting the right advice about mode of delivery.
That's great.
Could I say
yeah.
That certainly impacted my my decision the second time around. I was offered the chance for a VBAC, a vaginal delivery after cesarean, and I thought about that. I thought, what's the worst case scenario here? And to me, the worst case scenario was laboring for a long time, exhausting my body, exhausting my joints, and then ending up with a C-section anyways. And so I chose to go with a scheduled C-section the second time around after needing to have it for medical reasons the first time around. And I think, there's sort of a stigma with C-sections, like it's not a birth, or you somehow didn't do it right, but that's silly. And unless a vaginal birth is really, really important to you, which for some people it definitely is, it's still definitely, you are giving birth to this child. My first one came out butt first through a C-section. It's still birth. And guess what? When they go to kindergarten, nobody asks them how they came out. It's so important right there in that moment, but it stops being so important as you raise them.
Yeah.
You got that right. And with autoimmune conditions, the unpredictability of our illnesses, I felt more empowered and more comfortable having a scheduled
Yeah.
C-section, thinking this is one thing I can control with my IBD, my body, my baby, rather than being surprised or shocked or having something happen that I wasn't expecting. So that was something else that really was part of my decision-making process. Can you speak a bit, Mariah, to what it was like to flare in pregnancy? And then Dr. Dubinsky, I'll have you follow up with how you coach patients if they start to flare in pregnancy and how that is treated.
Sure. So during my second pregnancy, I had started med-free because that was what was sort of being advised to rheumatology patients at the time. And then I had a really terrible flare while I was pregnant. And it was difficult because I had a belly that I was dealing with, which was putting more pressure on my joints. I had a toddler that I was trying to take care of. And it was a real challenge. And so my biggest lesson from that was to have a plan in place with your doctor, with your rheumatologist, whoever it is. If you're trying to go med free, have a plan for what meds you would be comfortable with if you need them. Because I was in my third trimester, miserable, hormonal, enormous, trying to make these decisions that felt really difficult to make while there was actually a baby there. It would have been much easier if I had put a plan in place with my rheumatologist in advance. So, because with RA, for example, some women do go into remission naturally while they're pregnant. I was not one of those unicorns, but it happens. So if you wanted to try going med-free, I think that's valid. And you might go into remission, but you should have a plan for if you don't, because I didn't, and it was very difficult. And that set me up for a much more difficult postpartum period as well, because there we were in the third trimester fighting to get my RA under control so that I could deliver the baby, so that I could take care of him. And that certainly made it much more challenging.
Yeah, I mean, for us, it's really difficult. Unlike a joint, Mariah, not to say that it's any less or different, but we can't see what's going on inside the abdomen is what I was getting at. You know,
Right.
with arthritis or psoriasis, you can actually see that there are flares. And so what I tell my patients is that the reason why I need to get you under control, especially small bowel disease, Natalie, with stricturing, I can't have you have a bowel obstruction going for emergency surgery while you're pregnant. You know, understanding that we need to see, which I'm so excited, Natalie, that your doc had you do SCOs before. They were legitimately getting you ready for pregnancy. But the idea for us is, if they're flaring during, we do everything at all costs because we need to avoid surgery, right? Because, you know, especially early on, there's a huge pregnancy loss rate, you know, risk of miscarriage if you do surgery too early. And so what we do, I'll tell you, if patients were hesitant to go on biologics before and just somehow got pregnant and showed up and said, whoops, I never got an opportunity to start that med you told me, now I'm really flaring. And I'm like, there's no negotiation at this moment, right? I need to manage you so that your baby gets what it needs. So it usually means steroids if we need to urgently, like someone who's having a really bad ulcerative colitis flare who's being hospitalized, we have to get steroids on board and then start one of our biologics. Our faster acting would be infliximab or Remicade if they're not on that yet. That's the one we use most commonly in an acute emergency situation because of its, we know how safe it is in pregnancy. But essentially, we step up our game like we wouldn't normally, even in patients who are, you know, not pregnant. So we view this as a red flag. This is critical. I cannot have a woman going into preterm labor at 24 weeks. It's just not an acceptable outcome, which is why I tell my patients, I am happy to negotiate once you get to like week 34. That's when the baby could safely, if delivery and if something happens. But now's not the time to be negotiating because I'm here to get you better so your baby is good, right? Mama good, baby good. Let's keep focused on our plan, and then we can negotiate at the end. But right now, it's important that you let me help you because I know what you need. And it's hard to be in this emotional scenario about how you're feeling and not wanting to harm your baby. I say, give me control of the wheel. I promise you, I will not put you or your baby at risk, right? You got to find your right care team that you trust and say, here it is, take control of me because I cannot at this point.
And speaking of that end, you know, the postpartum period, once the baby is safely in your arms, Then that opens up a whole nother level of complexity for chronic illness mothers. They have to not only care for a little human baby, whether they're breastfeeding or using formula, they have to worry about their body flaring from that fluctuation in hormones, no telling what the disease is going to do. And that's always a big stress. Are there any symptoms or signs that you tell women to watch out for once they deliver with their disease possibly ramping up, even if they were in remission?
Yeah, so a couple of things that's interesting is that we do say that, you can flare because there's hormonal changes, right? That's what we talk about. There's a lot of women, and Mariah noted that some women say, like, I wish I was pregnant all the time, because there's definitely okay, an impact of progesterone, which is, considered to be sort of like an anti-inflammatory a hormone in a sense. And so the ability to have this glow that patients with immune diseases say in the third trimester, I was like, do not, don't come near me. I'm feeling amazing. And then there's this switch where prolactin, if you're breastfeeding and you lose that, sort of progesterone high after delivery. And so that in itself can change your disease severity or symptoms. It doesn't always mean flare. I do want to be clear that I have women, when they breastfeed, they have diarrhea. They have cramping. It's a hormonal stimulant that they're actually, I've had one patient had to breastfeed while on the toilet, so all things on the table.
We've all been there.
Okay.
Yeah,
So,
I'm think of it right now. So
okay.
that doesn't.
So you know what I'm saying? So I'm like, not every symptom is a flare. So let's logically think through. You were amazing up until I had labs throughout pregnancy, and in IBD, we do stool markers to show that you're not inflamed. We use calprotectin, for example, or we use ultrasound in our clinic at Sinai for pregnant women so they don't have to go through scopes immediately after delivery. We put our ultrasound probe. We can tell you in real time that you're not flaring, etc. So I think it's a matter of just understanding like which symptoms are flares versus not, and staying on your medication, and we'll work it out and we'll figure out how we need to approach your change in symptomatology.
And speaking of breastfeeding, Mariah, I know you breastfed your children. I'm currently breastfeeding my son. How did you navigate that with your medication and your illness? Was it hard to ever, with your joints, hold the baby up or utilize different parts of your back muscles?
Yeah, I mean, it can, women with rheumatology issues can have a flare afterwards. It's very common. And then that's usually like 6 or 7 weeks. It happened like clockwork with my first 2 babies. And it can make the physical aspects of parenting really hard. It's very demanding to hold a baby all the time, and everything you're doing, those teeny tiny snaps they put all over baby clothes. I could have throw them away, get some pajamas with zippers. You'll thank me at 3 o'clock in the morning. But there's a lot of tools out there that you can get different kinds of pajamas. I found when I was breastfeeding and also formula feeding, a nursing pillow so that you could be in the proper position and not stress your body extra was really helpful. If you're pumping, you definitely want one of those bras that will hold the pump in place so that you don't have to do it with your hands. And I also really depended on baby wearing a lot when my babies were little, because it was difficult for me to hold them safely. And so I would put them in a carrier, and then they could be close to me and I could take care of them. And it was less of a strain on my joints because it spread the weight out on my body. And so there's a lot of tools that you can use and ways that you can troubleshoot these issues. But it certainly is, it's a physical task for any mother. And plenty of new mothers end up with carpal tunnel and things like that from doing repetitive tasks again. So you want to think about how you're doing it and try to protect your joints as much as possible while you are.
When it comes to breastfeeding, Dr. Dubinsky, what are the benefits for baby and mothers? Anything directly related to IBD to help lower the risk of passing that on, or does it not make a difference?
Yeah, I always, because I feel bad for my moms who just, the baby didn't latch, or, and there's this sort of perpetuation that, oh, you need to give your baby as much immunity, and if you breastfeed, their microbiome would be different, and therefore they'll have less risk of IBD. To be fair, there's some studies that are proposing, at least in the IBD space, that breastfeeding may be protective, but at the end of the day, it's really about the microbiome and probably less about whether you breastfeed. It was more about the antibiotics they may have received in the first 2 years of life, or, it doesn't necessarily, there's so many things that could alter the microbiome once the baby is born out until 3 years of age. So I don't want to make it assume that everyone needs to breastfeed. I think if you can pump and use breast milk for as long as you can, that's equally as good, and don't feel bad about a bottle. It really has to be suited to your personal needs. It's not enough data for me to force you to breastfeed your baby is what I'm trying to, get at. Also, Natalie, I would say, chronic conditions have a high mental health burden. So we need to remember that we need to make it stress-free, worry-free, address anxiety, depression, because the postpartum period is tough enough. And then when you have a chronic condition and then later on a mental health comorbidity, please be open with your physicians and make sure that you manage postpartum, go on your medications if you need it. Please, make the best of your experience postpartum, and do not dismiss the hormonal changes and the risk of that just with having a chronic condition alone, whether you're pregnant or not.
That's such a key message, because oftentimes breastfeeding is such a labor of love for so many women. I formula fed my firstborn. I'm exclusively breastfeeding my third. So my children have been fed completely differently. But I think that it's just, at the end of the day, your maternal health, keeping your chronic illness under control, that's what's most important, is being present and being happy with your children and your family, rather than, dreading every time you have to feed the baby, or feeling the stress and the pressure of maybe not doing what you had wished to do. Just know that you're doing a fantastic job just being a mother with a chronic illness. And remember to have gratitude and grace for yourself along the way. And we've been talking about all the tools and different resources out there. And I think that it's really important, before we end this session, that we talk about everything that's out there to empower us as patients, because years ago, we didn't have resources right at our fingertips that can help educate us along the way, and our care teams as well. So Mariah, you have Mamas Facing Forward. Can you speak a little bit about that?
Sure. I mean, like you were saying, there didn't used to be these resources, and I wanted to connect with other mothers who had babies while living with chronic illnesses. I wanted to know that my life goal, my dream of becoming a mom, was a reasonable one, that I could do it. And there wasn't as much social media, there was nothing. So I started Mamas Facing Forward as a private Facebook group, which today connects moms and moms to be from all over the world. And it's a great place to, find a real person you can talk to. And it's a kind of a hive mind, that if you've got an issue that you're figuring out, you can jump in and ask for advice and troubleshooting. And then I also have, a few years later, mamasfacingforward.com, which is a website where I collect pregnancy and parenting resources that are aimed at chronic illness. So in some cases, we're creating those resources, and in some cases, I'm finding other resources that exist and putting them all in the same place, so that you can find resources to help you answer your questions, and to connect with other women, and just to feel supported and encouraged to know that you are allowed to want to have a family, even if you're living with a chronic illness. And there are resources and people out there who can help you along the way.
There sure are. And Mamas Facing Forward is an awesome resource at that. You should be so proud of what you've created for the chronic illness community. And some other great groups, IBD Moms, Brooke Abbott and Amber Tresca, have built a great community of women with inflammatory bowel disease. Whenever I have anybody reach out to me directly, I always point them in that direction. There's also the IBD Parenthood Project, which is the gold standard. It was created by the American Gastroenterological Association, launched in January 2019, and it is a resource of support. The gold standard, like I said, it takes away the gray area and really is black and white. Dr. Dubinsky, can you speak about We Care in IBD in that community?
Sure. So in concert with the our AGA publication and creating the IBD Parenthood Project, We Care in IBD was really developed to help guide physicians manage women and address, reproductive health at sort of the highest evidence based, in keeping with our Parenthood Project, and really gives you a preconception and pregnancy journey. So it's sort of like what I do analog version on Wednesdays is delivered through the web. So that's a resource that you'll be able to get all the facts and help you, in addition to the Parenthood Project, about managing IBD.
And then there's also studies that you can participate in. I was part of the Piano study, which looks at the safety and efficacy of biologics in pregnancy. I just completed that with my third born. There's also Mother to Baby, which looks at the safety of medications through all conditions. And my first two are part of that study. And as far as rheumatology, Mariah, what is that group working on right now?
So the American College of Rheumatology, 2 years ago now, I think, released some pregnancy and fertility guidelines, where they have information it's aimed for rheumatologists who are dealing with their pregnant patients, but it can also be useful for patients to understand, because rheumatologists are not often dealing with pregnant patients. So sometimes you encounter a rheumatologist who doesn't have a lot of experience with pregnancy, and these guidelines can be a really useful place to start. And we also recently did a similar webinar to this one that focused just on rheumatology issues, and that had some really great, the rheumatologists who are at the front edge of reproductive rheumatology spoke at this webinar, and it's now available on YouTube. So you could watch it if you had rheumatology questions.
That's wonderful. So look at all that is out there right at our disposal to help comfort us and guide us along the way to family planning. Dr. Dubinsky, Mariah, thank you both so much for being here with us today for this discussion.
Yeah, great to be here.
Yeah, thank you so much for inviting me.
Of course. And just a final message to women, as an IBD mom myself who has 3 children, be confident in your decision and know that you may look at your body after your pregnancy and have a renewed sense of love and appreciation for what you are capable of doing despite your chronic illness. Mariah, I'm sure you can feel this on a daily basis.
Yes. No, it's very cool to watch your body do the right thing for once. So that was an exciting part of pregnancy for me, for sure.
So give yourself credit, and one day at a time, 1 hour at a time, say yes to help, and just really work with your care team and make it a collaborative effort all the way around. Thank you so much for being here today.